morning, everyone. We're going to go ahead and get started, so if you can please take your seats. For those of you who may need, the bathrooms are just outside the doors to the left, and hopefully you all saw that we have a copy of the Maternal and Child Nutrition Supplement for you in your packet. It has also been launched online, live, and is open access, so you can look for that later. For those of us joining online, please type your questions into the chat box, and we will get to those during the Q&A session. And for those of you here as well, we will have a Q&A session towards the end, so please hold on to your questions until the end, and we'll have people with microphones, and so we'll get to those. For now, I would like to invite up Barbara Hughes. She is the Director of the Office of Maternal Child Health and Nutrition at the Global Health Bureau at USAID.
Thanks, Janice, and good morning and welcome everybody. Congratulations for getting here in the rain. Every piece of weather in this area seems to be some sort of challenge. Please forgive me for mostly reading remarks, but I want to make sure that I cover everything because all I'm really doing is setting a stage. The interesting stuff is going to happen here. So, good morning again and welcome. We're pleased to have you all here with us today as USAID's flagship Maternal and Child Survival Program, MCSP, launches a special supplement of the Journal of Maternal and Child Nutrition on how to strengthen nutrition within the health platform. Since Janice already said it was officially launched, I figured I could hold it up. Preventing maternal and child deaths is a key priority for USAID. Nutrition plays an integral role in this, ensuring that pregnant and lactating women and young children both survive and thrive. Over the past 10 years, in close partnership with governments and a myriad of other public and private partners, USAID has helped save the lives of more than 200,000 women and 5 million children. And in 2017 alone, USAID reached more than 22.6 million children with effective and often life-saving nutrition services. To date, USAID through MCSP has partnered with 32 countries to increase maternal and child survival and build resilient, accountable, and responsive health systems. Investing in nutrition through MCSP has been essential in complementing the agency's other nutrition efforts, and MCSP has partnered with 14 countries over the past 5 years to strengthen nutrition services in reproductive, maternal, newborn, and child health platforms. In particular, we know that breastfeeding is one of the highest returns on investment of any development activity. Every dollar invested in breastfeeding interventions yields an estimated $35 in economic gains. For more than 40 years, USAID has promoted and supported the scale-up of breastfeeding interventions to save lives, prevent malnutrition, and enhance the long-term health and development of women and children. As you will hear more about today and read about in the supplement, improving support for breastfeeding, both globally and at the country level, has been a key focus of MCSP's work over the past 5 years. For example, at the global level, MCSP has contributed significantly to global evidence and advocacy efforts. In Kenya, MCSP, in collaboration with the Ministry of Health and UNICEF, led the development of the first ever national-level baby-friendly community initiative implementation guidelines, monitoring and evaluation tools, and external assessment protocols. In these communities that use these, exclusive breastfeeding improved slightly, and pre-lacteal feeding practices decreased dramatically in just over 1 year. USAID prioritized tackling barriers to improving nutrition through health services by asking MCSP to review and produce global and local evidence on barriers to improving maternal nutrition, infant and young child feeding practices, and addressing maternal anemia early on in the program. USAID and MCSP have then taken that evidence and worked hand in hand with governments to strengthen national programs. In Zambia, Guatemala, and Ghana, USAID through MCSP has worked closely with the Ministries of Health to develop and/or enhance existing e-learning courses for improving the knowledge and service provision of health providers, to include modules that focus on key topics of maternal nutrition. Today, we will have the pleasure of hearing about other experiences of improving nutrition through the health systems directly from Tanzania, Mozambique, and Malawi. Through MCSP, USAID has formed strategic collaborations with the global reproductive, maternal, newborn, and child health communities to ensure that nutrition is strengthened and prioritized in relevant guidelines, policies, protocols, and health management and information systems. Our efforts ensure that this information and evidence also reaches countries and sub-districts to catalyze change. Guided by our multisectoral nutrition strategy and the U.S. Global Food Security Strategy, USAID works closely with host countries to reduce malnutrition while also building in-country capacity to address nutrition. Nutrition will continue to be a key component for USAID's work to prevent maternal and child deaths and promote healthy individuals and self-reliant societies. Today, we look forward to sharing with you the critical importance of and key lessons learned through USAID's investment in MCSP to strengthen nutrition in the health platform at the global and country levels. Thank you.
Thank you, Barbara. Unfortunately, due to inclement weather, our next guest, Dr. Zulfi Bhutta, was not able to join us here in DC in person today, but we do have a video of his presentation that we're going to play next. And just to note also that Dr. Bhutta is a key contributor to the supplement, and his team have an article in the supplement as well. So we'll go ahead and watch the video now.
Much for permitting me to record and send this presentation in advance. I was dearly hoping to be with you today, but the weather in Toronto with the anticipated 30 centimeters of snow has put paid to any plans. So I'm deeply grateful to be able to share this with you as a recorded presentation rather than risk traveling and being stranded. So the topic of my presentation is our recent work that's appeared in the supplement that you have in your hands around the evidence base for integrating nutrition within health systems and what are the lessons from what's available in the electronic literature. And the reason to undertake this work was principally the basis for global interest in malnutrition, in that scaling up evidence-based interventions was the norm, but vertical programs, by and large, had failed to live up to the expectations as well as the opportunity to have impact at scale, particularly in terms of integration within health programs. Many of the prevailing contexts for nutrition interventions, particularly in conflict settings and humanitarian emergencies, are also increasingly complex and require integration of nutrition within existing programs. And it wasn't very clear as to what is the point within a health system, particularly if you take the building block context, where one could approach this on the basis of what the literature presented. So to undertake this systematic review, we set ourselves a basic objective, is to map the existing integration platforms, develop a conceptual framework for looking at this, and review the evidence on integrated health and nutrition programs and their impact on specific nutrition outcomes. And I'll make some clarification on how we define integration. So our conceptual framework isn't too complex. And as you can see from here, we looked at the opportunities for integrating this in the context of both supply side and demand side factors. The yellow rectangles within this conceptual framework represent the building blocks that we have from available information on health systems, and they reflect governance, financing of health systems, information as well as opportunities for service delivery. We also looked at supply chain and principally looked at point of use integration of services using health workers, and also the elements that needed to go in place if the programs were to be called truly integrated. We needed to start with a definition, and the definition that we adopted was modified from several previous efforts in this direction. We define nutrition integration as the extent of adoption and eventual assimilation of nutrition interventions into critical health system functions, which are the building blocks within health systems, to look at the nuts and bolts as to how that had been achieved. Our inclusion criteria were largely peer-reviewed publications, looking at programs and not necessarily small studies, which had integrated nutrition-specific interventions with other programs. We did not have a date restriction, and to make it explicit, we did not look at nutrition-sensitive programs in this particular exercise, although that also needs to be done in the context of completing the picture. We, as I've mentioned, excluded standalone programs. We excluded where things had been delivered as a package, but not evaluated separately, because it would be impossible to look at the impact of one or the other. And those interventions where there was the converse, which had not integrated nutrition interventions into existing health systems, but had taken elements from health and integrated those within standalone nutrition programs. That latter process also needs to be evaluated in its own right, but we are uncertain as to how policy relevant that might be from the context of looking at close interaction of health and nutrition. Our methods were standard. We used PRISMA guidelines for evaluating systematic reviews. We looked through all the major electronic literature and websites until October 2017. We had 2 abstractors doing this independently using Covidence, and a third person who would resolve any disagreements on study selection and criteria. We mapped the integration, as I had mentioned, based on the primary programs. And we looked at the 6 building blocks as they had been specified in the reports and the evaluations of those particular programs. We ascribed a mean score, and I'll show you a rating scale for how we assessed the completeness or lack of integration within the health system building blocks. And we presented this graphically, as I will show you, using some spiderweb charts. And we attempted to, although it can be argued that with a limited number of studies, much of this quantitative meta-analysis of impacts or outcomes needs to be taken with a pinch of salt. So the extent of integration in each building block was rated as either totally not integrated or partially integrated, or what we ascribed as the gold standard, which is really fully integrated within those specific elements of either governance, financing, information systems, health workforce, supply chain, and service delivery at the point of contact. So what did we find? Our main findings relate to the total universe of the evidence that we had. And as you can see, although we saw thousands of records and we have screened close to 14,000 titles and abstracts, the vast majority were ineligible based on the stringent criteria that we had used. We tried to look at around 450 full texts, of which a substantial number were reviewed. We could not locate or find 111 full text reports, and these are the descriptions as to why several were excluded out of this. We eventually ended up with 45 studies, of which 5 studies had not been identified in the electronic literature and had to be hand searched and based on individual experts who had been approached as part of this exercise. So these primary programs or integration platforms, as we state, include the following. And I shall go through these one by one. We looked at particularly integrating nutrition within existing IMCI or integrated community case management programs. And these are the bulk of what I'm going to report on. These are 12 studies from 6 programs. We looked at the integration of severe and moderate acute malnutrition into health services, which is of great interest because the vast majority of therapeutic feeding programs or feeding for MAM are standalone programs. And we also were interested to see how many reports had looked at integration of nutrition into these campaigns, Child Health Days in particular, that have been so successful in parts of Africa and Asia. We were interested in looking at integration of nutrition into immunizations, just given the potential of doing better within the vaccination program or the vaccination system, which is such a robust system, it exists as a vertical program. And we tried to look at which large-scale programs had looked at integration of nutrition within social support programs, both those that related to early child development and cash transfers. So what about IMCI and integrated community case management? As you can see from the spider plot, it looks as if these have been integrated fairly reasonably across the domains of governance, information system, supplies, and technology. And this may relate to the nature of some of these interventions, that they were added. Two components that were largely within district systems or systems where ICCM or IMCI was well established. So overall, looking at the spider plot, with the exception of perhaps the supply chain component, most seem to be fairly reasonable around the building blocks of the health system. And indeed, when you look at the impact from these 12 studies that I've mentioned, it looks like that a lot of process indicators were very well achieved. So overall, on nutrition, 27% greater rates of exclusive breastfeeding, and by 6 and 9 months of age, also a trend, although did not reach significance on improving breastfeeding and complementary feeding within this age group using random methods. We don't see an impact on nutrition outcomes in these programs, which is not altogether surprising, but the most interesting aspects are the features that relate to detection and care seeking for children with danger signs and perhaps management of children with pneumonia. So no evidence that integrating nutrition within health programs related to IMCI and ICCM had any adverse impact on the performance of health workers in tasks to detect serious illness. And that is quite a salutary finding because it supports getting things into these programs where they exist. What about management of SAM and preventive management of moderate acute malnutrition? Predictably, when we look at how these have been integrated, we find that much of that is on the supply and commodity side and in service delivery at the point of contact. So you see that these have performed fairly well in terms of information availability in our evaluation of how this was done at the point of use. And that essentially means that people were able to roll out commodities such as ready-to-use therapeutic foods and ready-to-use supplementary foods. However, when you look at how well were these integrated in terms of nutrition planning within the health system programs that they were integrated into, we find that on information systems, on financing, and on the overall governance, integration was less than optimal. So certainly a long way to go in terms of achieving the maximum benefits. We could not undertake a meta-analysis given the limited number of studies, but the evidence that we had broadly supported this approach with trends in the right direction. And as you can see, the recovery rates in general were reasonable where there were robust programs, such as in South Africa, community programs, and in Zambia. And we also found that where these programs were in HIV positive populations, that we found evidence of benefits in terms of antiretroviral therapy, which was already in place, and nutrition integrated within this had a benefit in terms of reduced mortality. Obviously, this is not an effect of nutrition only. It just supports the finding that you could do nutrition integration without a negative impact on the primary focus of the health system intervention, in this case, HIV therapy of malnourished children. Immunization strategy is more or less the same. We find that, again, because immunization is a vertical program with largely vaccinators and service delivery components, that we find evidence of integration largely at the level of service delivery. And here it's much more on the service delivery component in human resources, and much less, as you can see, around governance and information systems. And for several of the other components, we could not find any evidence. So this becomes a diamond plot rather than a spider plot because other evidence or components were not available. But by and large, again, the experience from these integrated immunization programs indicate that you could achieve benefits in terms of breastfeeding in the first hour, where these were linked to existing health workers providing early immunization, such as BCG, et cetera, and that in the 3 studies where they looked at impact on weight here, in that sense, there was a reduction in underweight within these integrated programs. On the social sector, less than satisfactory. We find a very limited set of studies, 2 on ECD, 1 on cash transfers, and we really could neither evaluate the extent of integration nor undertake any impact, except to say that there was some indication, albeit limited, that there were some benefits in terms of weight for each Z-scores and BMI Z-scores within the population studied. So a lot more work needs to happen in this instance. So what are our key messages as I close, ladies and gentlemen? One is that nutrition-specific interventions can be integrated within a range of programs and not small studies. So we're talking about integrated management, childhood illness, and community case management, childhood days, immunization, ECD, etc. And that most common components of nutrition-specific interventions which have been integrated relate to infant and young child feeding. But there are also elements of supplementary feeding and micronutrient supplementation and early detection of malnutrition that seem to be possible by integrating within health programs and existing health workers. We are disappointed by the lack of rigorous quantitative data and information on nutrition-specific indicators in these programs. Many of these were just process indicators, but the overall evidence suggests that these are, by and large, effects in the right direction, with no evidence of an adverse effect on the delivery of the primary program. So I think that's the key message, that you could do this without taking people away from their primary mission. Immunization systems are notorious in terms of avoiding integrating things because of the potential of perhaps reducing their overall coverage rates. And our data indicates that the evidence is to the contrary, that you can achieve benefits without necessarily taking people away from their principal focus of coverage. The domains of governance and human resources as service delivery appear to be well integrated in most instances, but financing, information systems, and supply chain were generally lacking in terms of true integration. People had attempted to set up their own supply chain rather than use the existing health system supply chain for better effect. So to conclude, I'd like to suggest that while there is scarce data around integrated nutrition programs and the evidence mixed, there is tremendous potential. And our review suggests that this potential should lead to more activities in this particular instance, with perhaps future studies focusing on the cost benefits and cost effectiveness. And if we move in this direction, we would very strongly advocate that we should look at all elements of the building blocks of the health system to ensure efficiency and long-term sustainability, which will also allow you to evaluate how truly integrated these programs are, and if the integration would lead to perhaps cost savings in terms of utilization of existing personnel and existing supply chain systems, existing information platforms within the health systems per se. Thank you very much for your attention. I'm very sorry that I'm told that the technology does not permit questions, but our paper is available, and we'd be very happy to receive feedback by email or any other mechanism. Thank you.
So thank you to Dr. Bhutta for sending us that video. I would now like to invite up Dr. Justine Kavli. She's the nutrition team lead at USAID's MCSP for nutrition.
Good morning, everyone. A warm welcome to all of you here in the room today and those of you online. I'm really delighted to provide the framing remarks on behalf of USAID's Maternal and Child Survival Program, MCSP, on strengthening integration of nutrition within the health platform Where are we and what does it take? So nutrition is fundamental to good health. Malnutrition is responsible for much of ill health and early death, which places burdens on health systems and societies. As shown in this map, nearly every country in the world is affected by multiple forms of malnutrition. Moreover, 1 out of every 3 countries faces high levels of child stunting, as well as anemia and overweight amongst women. According to the latest Global Nutrition Report, progress has been slow. While the global prevalence of childhood stunting has gradually declined from the year 2000 to 2017, we know that the absolute numbers of children who are affected by stunting has actually risen in Africa due to population growth. As well, we know that this masks differences at the subnational level. In addition, child overweight is rising. The global prevalence of anemia amongst women of reproductive age and pregnant women has also stagnated, as seen in the top 2 blue lines. In addition, overweight and obesity amongst adult women is steadily rising. The SDGs and the World Health Assembly targets for nutrition for 2025 provide an impetus and a recognition to accelerate global action to address the pervasiveness of malnutrition. Yet, countries are off course on targets, with limited progress in exclusive breastfeeding. Lack of national or subnational targets, or limited data or no data on the nutrition situation make it difficult to track progress in line with currently implemented strategies and interventions. It's clear that accelerated efforts are needed for us to reach the Sustainable Development Goals, as current trajectories show that only 24 to 44% of the gap in certain forms of malnutrition will be alleviated by 2030, and the burden of child overweight is actually increasing. Encouragingly, there has been increasing momentum through the Scaling Up Nutrition or SUN movement, through global guidance to act at country level, and financial commitments through the UN Decade of Action on Nutrition. This has brought increased visibility, coordination, and funding for nutrition action. While nutrition-sensitive funding for the underlying causes of malnutrition has outpaced nutrition-specific funding for the high-impact nutrition interventions, which has fallen short of needs, it's clear that we need to cost interventions at the national and subnational levels within health and other sectors, and we need to align these with nutrition plans at the country level, nutrition burdens, and set realistic targets. This can allow us to meaningfully improve nutrition and health outcomes in the long term. Actual service delivery of nutrition interventions within the health system is often not at the intended frequency or intensity. Yet, there's little evidence or reflection of where, why, and how implementation occurs. In our experience, and that documented in several global reports and others, many of whom are in the room with us today, there are several opportunities for measuring progress I'd like to highlight. First, we need to strengthen the quality of routine data and support health providers on how to interpret and use data for making decisions for the care of women and children during routine services. And further upstream, create dialogues for targeting approaches at the health facility or subnational levels, which are often not discussed. Second, the process of implementation, successes and challenges, and benchmarks of progress should be documented. Third, in the face of the rollout of multiple interventions, whether it be micronutrient supplementation, fortification, or dietary diversification efforts by multiple projects and partners at the country level, should include monitoring, sharing of data, and lessons learned amongst implementing partners. Fourth, we need data collected on the type and severity of malnutrition and micronutrient deficiencies, as well as coverage of the very interventions we are rolling out, so we understand the reach of interventions like baby-friendly and dietary diversity promotion, and for assessing progress and keeping ourselves accountable. Better measurement includes tracking what we do across the continuum of care. MCSP works to strengthen quality services with the Ministry of Health at the facility during antenatal care, lactation support postpartum, and during well and sick child visits. Reinforcing that information at the community level and working alongside sectors for an approach that's comprehensive, multidimensional, and adaptable to country needs. MCSP works in 14 countries to improve nutrition health programming, to take global perspectives and evidence, to root them in country realities to strengthen the quality of nutrition services within the RMNCH platform, and to build country capacity and leadership across health systems. Today, we're delighted to share with you the how-to of integrated nutrition health strategies and approaches from 3 country perspectives. We'll highlight successes and challenges and provide considerations for sustainability and scale-up with the health systems approach, and we hope this contributes to the nutrition health integration dialogue. Thank you very much.
Thank you, Justine. All right, we'll get started with some of our country experiences now. So I'd like to introduce Ms. Melanie Piccolo. She's the Senior Nutrition Advisor for MCSP in Mozambique.
Good morning. I'm delighted to be here today to present on rethinking strategies to address micronutrient deficiencies in children under 5 in Mozambique. I wanted to start by giving you a snapshot of the country's child health and nutrition situation. It is estimated that about half of Mozambique's 28 million people suffer from absolute poverty. That means that they cannot access the minimum conditions to live a healthy life. As you can imagine, food security is a real concern in Mozambican households, such so that 43% of children under 5 are stunted. That means that about 1 in every 2 Mozambican children will not reach their full developmental potential. What is most striking is that if you see the yellow line on the graph on the left, this prevalence did not change in the last 15 years. The data from the latest demographic health surveys showed that only 15% of children 6 to 23 months meet the minimum criteria for a minimum acceptable diet, that is, consuming 4 or more food groups per day and at the right frequency for age. So micronutrient deficiencies are also highly prevalent. It is estimated that about 2/3 of children under 5 are anemic, which may be a result of iron deficiency, and approximately the same proportion is also vitamin A deficient. But the country has made great progress in reducing child mortality, which resulted by increased demand investment in life-saving maternal and child health interventions. So we know that if investments are made in nutrition, this nutrition situation can also rapidly change, and it's likely that we'll see further reductions in child mortality. USAID, through the Maternal and Child Survival Program, supported the Ministry of Health in strengthening the delivery of preventive and curative interventions targeting children under 5 and their mothers, integrated in reproductive, maternal, neonatal child health services in 2 provinces of Mozambique, Nampula up north in red and Sofala in yellow in the center. You can see from the graph, the map here, that Nampula is the province with the highest prevalence of stunting at 55%. In light of this, MCSP implemented a more intensive support approach in Nampula and a lighter support approach in Sofala. Interventions strengthened, including interventions to reduce micronutrient deficiencies, including vitamin A supplementation, the delivery of micronutrient powders to improve complementary feeding, and the promotion of adequate maternal and infant young child feeding. The government of Mozambique has for long prioritized interventions to address micronutrient deficiencies. The health sector strategic plan naturally includes the interventions that are delivered through health services, including vitamin A supplementation, deworming, micronutrient powders, and counseling and cooking demonstrations to promote dietary diversity. The Multisectoral Action Plan for the Reduction of Chronic Malnutrition includes these interventions as well, but goes beyond them to also include interventions that are delivered by other government sectors, such as mass food fortification of staples, which is mandated by the Ministry of Industry and Commerce. So while this case study focuses on the interventions delivered to the health sector, which is the theme of this journal supplement, as well as MCSP's programming, it does so in the context of these multisectoral interventions. So we're providing you with program considerations for the planning, implementation, and monitoring and evaluation of vitamin A and iron deficiency reduction interventions integrated in health programs and targeting children under 5. 3 interventions specifically are discussed: twice yearly vitamin A supplementation, point of use fortification, micronutrient powders, and promotion of dietary diversity. As I mentioned, under MCSP, we supported the delivery of all these interventions. So as we discuss progress to date and challenges, we bring you a perspective of our experience from the field. Let's look first at vitamin A supplementation. Vitamin A supplementation has been implemented in the country for the past 20 years. And in that process, we've been trying to find the best delivery model that ensures both high coverages and low costs. So, when the intervention first began to be implemented in 1999, it was delivered through immunization campaigns, and coverages were high, at about 80%. Concerned about the sustainability of this intervention, the Ministry of Health made the decision to integrate vitamin A supplementation in routine child services. And this reduced cost of campaigns, but as costs reduced, so did the coverage. So, after 5 years of struggling to get coverages back up, the Ministry of Health resorted back to campaigns, delivering twice yearly national health weeks, which really focused on providing vitamin A supplementation, but also included other interventions. And so coverages went back up, and this was the modus operandi for about 7 years. But as the country faced economic recession and decreased external investment, the Ministry of Health began phasing out campaigns in 2016, and in 2018 launched the planning guide for strengthening vitamin A supplementation and deworming in routine child health services. The guide focuses on increasing coverage of vitamin A supplementation in routine health services by generating more demand for the intervention and for reaching more children and reaching them equitably by using the RED, the Reaching Every District, and the Reaching Every Child strategy. You can see that as the Ministry of Health phased out campaigns, the coverage went back down. So we're still facing challenges to get coverages up in routine child health vitamin A supplementation. First of all, caregivers do not give the same value to vitamin A supplementation as they give to immunizations. So once the child completes the immunization calendar at 9 months, caregivers do not bring back children to the health facility to receive other preventive services, such as vitamin A supplementation. Secondly, even when caregivers bring their children back because they're sick, healthcare providers are not providing vitamin A supplementation in these contact points. Many times, the supplements are not even available at these contact points. Third, there is a low capacity to aggregate data from all delivery channels. So the well child visits at the health facility, the community outreach services, the mobile brigades, and the delivery of vitamin A supplementation through community health workers. We expect that to some extent this will be addressed by the rollout of just approved new child health registers, which MCSP supported. But it is important that the government monitors potential pitfalls of the system so that health workers do not go back to parallel reporting to address the reporting requirements of the Nutrition Department of the Ministry of Health. Additionally, there is a low capacity for doing appropriate microplanning, which is the essence of the RED-REC strategy. It is important that if we are to reach children equitably, We understand what is our eligible population, we plan resources to reach them, and that we implement the activities to reach them equitably. So the Reaching Every District, Reaching Every Child strategy has been implemented in several African countries and shown to increase immunization coverage. So we believe that this platform is appropriate for integrating other interventions, such as vitamin A supplementation. Let's look now at micronutrient powders. While this is a recent strategy that the government has endorsed to reduce iron deficiency in children, great strides have been made to integrate this intervention in routine child health services. A strategy was developed. SBCC materials for promoting MNPs in infant young child feeding counseling have been developed and rolled out in specific provinces, such as in Nampula and Sofala, where MCSP was present. And micronutrient powders indicators have been integrated in the child health cards and the new child health registers that have just begun to be rolled out. However, MNPs have only been available through short-term pilots and in selected geographies, in part due to the cost of the commodities. There is also no evidence at this point that MNPs are a cost-effective intervention to implement in Mozambique, so there is a real need to generate more evidence in this regard. What we've learned from field implementation in MCSP and other projects is that the provision of MNPs needs to be anchored in a well-designed SBCC strategy that uses community leaders to build trust in this new intervention and promotes caregivers' acceptance of MNPs and ensures that they provide MNPs to children and that they follow the supplementation course. Finally, we'll look at the promotion of dietary diversity. The Ministry of Health recognizes that investing in food-based strategies is the only way to improve micronutrient status in a long-lasting and sustainable manner. For long, the promotion of enriched porridges, which are prepared from flour and water, and are enriched with other foods such as mashed fruits, green leafy vegetables, some groundnuts or oil, and shredded meat or eggs, has been the gold standard for complementary feeding counseling in Mozambique. MCSP conducted a formative assessment using the trials of improved practices that showed that enriched porridges really are all that mothers give to children from 6 to 23 months. And this is a critical stage for development. However, we know that adequate complementary feeding goes beyond enriching porridges and should include considerations of the quantity, the consistency, the frequency of feeds, as well as adequate hygiene practices and responsive feeding. And this is lacking in the country. To address this, the Ministry of Health adapted the generic UNICEF Infant Young Child Feeding Counseling Package, which many of you may know, to the Mozambican context. And this included adapting the messages so that they resonate with the target audience. The rollout of this package has been very slow. Only where partners like MCSP were present have the package been distributed and training and supervision been provided for its rollout. At health facility level, the use of the counseling cards has not been as effective as at the community level due to the high caseloads and providers' poor counseling skills. What we've learned from our Trials of Improved Practices assessment is that we also need to contextualize messages to the cultural context in which we are implementing activities. For example, the messages that we used in Nampula could not be the same that we used in Sofala. Because Nampula was our focus implementation site, we developed a counseling guide specific to Nampula and a supporting cooking demonstration material so that mothers could understand how they can address the barriers that we encountered for appropriate maternal and infant young child feeding, and identifies ways to diversify the diet. Taking all of this into account, the following recommendations for addressing micronutrient deficiencies in children under 5 in Mozambique have been set forward by the authors. Resources should be allocated to monitor the current prevalence of micronutrient deficiencies in the target population. For example, the latest nationally representative data we have for vitamin A deficiency dates back to 2002. And since there has been widespread production of orange flesh sweet potato, which now accounts for 1/3 of the total production of sweet potato in the country. Evidence has shown that orange flesh sweet potato and products produced from it are highly acceptable in the Mozambican diet. So it is possible that a segment of the population accessing and consuming orange flesh sweet potato is no longer deficient. Additionally, the fortification of oil with vitamin A has since become mandatory in the country. So it is also possible that the urban population and peri-urban population accessing this may also no longer be deficient. So we need evidence to show that this is the case. It is also important that the evidence is generated on the intervention's costs, their cost effectiveness, feasibility, and acceptability in the country context, so that the government makes an informed decision of the interventions. Perhaps micronutrient powders should be rolled out across the country at the national level, or vitamin A supplementation should continue, or other interventions, but we need to know what segments of the target population we should really invest in, so resources that are scarce are invested appropriately. Priority should also be given to getting these guidelines, so beautiful, that we developed from the desk to the field. It's important that resources be planned, forecasted, and supplied to meet needs in an equitable manner through the employing of microplanning and the Red Rec strategy. Demand generation activities to sensitize Mozambicans of the importance of a varied diet and adherence to the existing micronutrient deficiency prevention strategies are key. And MCSP has shown that cooking demonstrations, theaters, songs, group talks, and individual counseling through home visits are effective strategies. Finally, we recommend that the government and all those interested in supporting the government consider the development of a cohesive national strategy for the prevention and control of micronutrient malnutrition to ensure that all of these multisectoral intervention efforts are coordinated, harmonized, and cost-effective. I wanted to end by saying that after the article, there is a letter of the head of the Nutrition Department of the Ministry of Health endorsing these recommendations, which really sets us for the sustainable process to reduce micronutrient deficiencies. Thank you.
Thank you, Melanie. It certainly gives us a lot to think about in terms of cost effectiveness and data-informed interventions. I'd like to now introduce Ms. Florence Bawanali from MCSP Malawi. She is the former nutrition advisor there.
Good morning, everybody. My presentation is a phased approach to scaling up the baby-friendly hospital initiative, BFHI, in Malawi. And I'll start by looking at the exclusive breastfeeding rates that fluctuated in Malawi versus the declining neonatal mortality rates. The baseline for baby-friendly or for exclusive breastfeeding in Malawi was done in 1992, and it was at 3%. Concerned by this, the Ministry of Health decided to launch BFHI with the support of UNICEF. Between 1993 and 2004, 26 facilities became baby-friendly. And BFHI came to the peak by 2010 with a rate of 71%. However, due to funding shifts and minimum monitoring at facility level, that is, BFHI declined. So much so that DHS of 2015-2016 reviewed a rate of 61%. While at the same time, for neonatal mortality, in 1992, the rate was at 41 per 1,000 live births. And DHS 2015-2016 reviewed a rate of 27 per 1,000 live births. At this particular time, Ministry of Health had prioritized newborn health, both at facility and at the community level. This was done by scaling up essential newborn care, as well as kangaroo mother care. Improved breastfeeding practices may have contributed also to the improved neonatal mortality we see or we saw. MCSP provided technical assistance to Ministry of Health by revitalizing and scaling up BFHI, and also by strengthening integration of family planning, immunization, newborn health, and BFHI. There is strong evidence that BFHI improves breastfeeding practices such as early, exclusive, and continued breastfeeding. BFHI is implemented around the world, although many countries have problems sustaining the initiative. In view of the revised BFHI guidance, countries should be aware that BFHI is one important platform for improving breastfeeding outcomes. Malawi had prioritized the revitalization and scale-up of BFHI because the initial BFHI they implemented gave them a good story. They also prioritized because the breastfeeding indicators had started to decline. The Malawi case study, therefore, has got 3 objectives, which are to discuss the phased approach to BFHI scale-up, to describe successes, challenges, and lessons learned from the phased scale-up of BFHI, and lastly, to describe the next steps and the future of BFHI in Malawi. The BFHI scale-up used a phased approach. And the phased approach, phase 1, was when MCSP supported Ministry of Health with the revitalization of BFHI. Also supported Ministry of Health with the updating the training materials by using the 2009 guidelines and refreshing the master trainers that were there for the 1993-2004 BFHI that was implemented via UNICEF's support. Also trained staff in the 18 initial facilities that we worked with between MCSP and the Malawi government. The key approaches that were used were like task shifting, where BFHI was oriented to more cadres than just the technical staff. The establishment of task forces so that they could track the progress of implementation, and monitoring, coaching, and supervision of various facilities as regards to the needs per every facility's need. The chart that we are looking at the moment is indicating 2 phases of the process. The blue chart is for the initial phase, where initially at the takeoff of the program, MCSP supported the Ministry of Health to conduct a stakeholders meeting to solicit support of those particular stakeholders for the program. A refresher training, as already indicated, for the master trainers that were there for the 1993-2004 implementation of BFHI. And again, the very mentoring and supportive supervision that MCSP actually supported MOH with, plus conducting external assessments for the various facilities. Phase 2, okay. The green part actually is we are looking at activities that took place in phase 2, where we see 30 new master trainers emerging. And then MOH and MCSP reaching out to more 36 new facilities, which in total added to 54 facilities out of the 28 districts. And then conducting the external assessments, which ended up in 3 of the facilities that were assessed becoming baby-friendly. And 2, they also passed the assessment, but by the time the project was closing, they had not yet been recognized by MOH. BFHI scale-up aimed to improve breastfeeding counseling and practices. As a component of the health system, BFHI was integrated into immunization, family planning, and newborn health. MCSP also supported the Ministry of Health in the strengthening of the integration. For immunization, 1,400 community volunteers were oriented to BFHI. And routine key messages for immunization were actually part of the game, because for immunization, they went down to the community level and reached out to the community volunteers who track the status of vaccinations for the children. So BFHI took that as a chance that as this was being tracked, could they also track down the status of exclusive breastfeeding for the very same babies. For family planning, lactation amenorrhea was the method that BFHI failed. Messaging BFHI messages in family planning messages could actually do the trick. So when developing messages for lactation amenorrhea, messages of BFHI were also included in the materials. For strengthening care and feeding of the small and the sick babies in Malawi, MCSP and Ministry of Health trained the staff in 8 of the health facilities, and they were trained in essential care for small babies, as well as conducted a bottleneck analysis to assess at what point the care was, or in terms of the quality of care. Looking at achievements, the figure that we are seeing illustrates the trends for early initiation. And we used the routine DHIS2 data that was collected pre and post implementation period for the 18 facilities that we initially dealt with. And this was from August 2016 to December 2017. What is shown is that we see that both two regions of the country, which are the central and southern regions, their rates actually increased. While we see one of the regions, which is the northern part of the country, we had a decline in the rate of early initiation for breastfeeding within 1 hour of birth. Quality of data may have been responsible for the fluctuations that we see in these graphs, as well as the one that we also saw as a drop for the northern region. Over 80,000 women received counseling on breastfeeding, and MCSP actually supported building the local capacity at all levels. Did we have challenges? The key challenges, indeed, were available, and they included inadequate pre-service curricula on BFHI, so much so that health workers qualified without gaining quite a lot of skills as regards to the infant feeding. Understaffing and overloaded health facilities was one of the major challenges. Monitoring and evaluation at facility level as BFHI was being implemented was one of them, as well as linkages between facilities and the community as mothers actually were discharged home from the facility. Data quality is one of the major challenges that were there. What do we think would be the way forward for BFHI in Malawi and its sustainability? Integration into national multi-sector and nutrition strategies, as well as integrating into clinical protocols, as well as integrating into the pre-service curricula is one good way forward for BFHI in Malawi. Routine supervision at facility level, as we saw that previously, that was responsible also for the previous decline. We also see that incentivizing, which involves recognition of facilities once they've implemented the initiative quite so well, is another way forward. Allocating resources, the domestic resources, by government to BFHI as a program is another way forward. And lastly, improving the linkages between the facility and the community would actually do BFHI as a program quite good. I thank you so much for listening.
Thank you, Florence. I think that was an excellent example of we know things that work, but challenges that still quite exist to make it really effective. I'd like to now introduce Ms. Lemi Mabuga. She's the Family Planning Advisor for MCSP in Tanzania.
Good morning, all. I'm so proud to stand in front of you this morning to present on the integration of nutrition and postpartum family planning services in Tanzania. And this was a formative research which aimed at informing program design. In Tanzania, I'm going first to give you a snapshot of the key indicators for the nutrition, family planning, and infant mortality. And I will start with nutrition family planning indicators. And if you look at the bottom orange line, it shows that we still have substantial unmet need for family planning throughout the 10 years. And contraceptive prevalence rate or modern contraceptive use is still low. We are still at 32% among the current married women. And the stunting prevalence, the line in green, it shows a decline over time, and exclusive breastfeeding has increased over time. If we go to the infant mortality graph, we see a decline over the 10 years, and this is likely due to the implementation of routine immunization services in the country, but also vitamin A supplementation and prevention of mother-to-child transmission of HIV, plus we have improved in management of common childhood illnesses. This slide shows the significant health benefits if mothers space their birth to the next pregnancy for at least 24 months apart. For the child, they will have benefit in the side that the stunting and underweight levels will reduce. Born too small, too early, or low birth weight, and the infant will be likely to die early. For mothers, breastfeeding will improve, and this will improve health of the infant. And mothers will have more time to recover physically and nutritionally between birth, and this will lead to lower risk of maternal death. So there are opportunities existing for integration of family planning and nutrition services, and this need to maximize routine contact points with women in the health system. We see women go to the health facilities in a number of needs or in different time points, but in the box there we think it's critical time points where mothers from time of birth to postpartum period, providers can reinforce information to these mothers on immediate initiation of breast milk, also on maternal nutrition, issues surrounding of exclusive breastfeeding for the first 6 months, information on postpartum family planning use, including lactational amenorrhea method, and also introduction of complementary foods to the infant who has reached the age of 6 months, but also information around return to fecundity. But in most cases, these opportunities are missed, and these services are provided in silos. So from the previous diagram, we see that there are linkages between nutrition and family planning services, and this can be provided during routine services. We see exclusive breastfeeding, which is recommended for the infant from when it is born up to 6 months of age, can automatically be used by a mother who has given birth, but also has a baby of under 6 months, and she has not seen her menses. This method, I'm sure many of us, we don't know what is lactational amenorrhea method. This is the short-term method of family planning that breastfeeding women can use up to first 6 months of life if they exclusive breastfeed and their menstrual has not returned. Complementary feeding is recommended to a child when it has reached 6 months, And this can trigger now, if the mothers start giving food to their infant, it can trigger ovulation to come back. But this can also apply to mothers who start introducing food prior to 6 months, because they reduce the frequency and duration of breastfeeding, and that can trigger ovulation. Optimal maternal nutrition will lead to infant and young children nutrition. So this is the program, MCSP in Tanzania, which is providing technical assistance to the government of Tanzania to improve the delivery of reproductive, maternal, child health to the facility level, but also at the community interventions. We invested at the communities because we know there are some remote families or remote communities which also are in need of health services. And we had comprehensive intervention in Mara and Kagera, and these are the 2 regions where the formative assessment was conducted. In Kagera, we still have high stunting prevalence. It's at 50% of children under 5 are stunted. And in Mara, it's 33% child who are stunted. In both regions, we have a higher total fertility, low contraceptive prevalence rate, and high unmet need for family planning than the national average. So these are the study objectives. The first one was to examine barriers and facilitating factors for optimal nutrition practices and postpartum family planning use. The second one was to gain understanding of perception around links between maternal, infant, and young child nutrition and postpartum family planning, and how this can inform integrated programming. So we applied 2 methods, qualitative method. The first one was in-depth interviews, and we conducted these with mothers of infants less than 1 year, grandmothers, health providers, and traditional birth attendants. We also had focus group discussion with community health workers, fathers, and community leaders. And these are the findings that breastfeeding initiation is often delayed, and prelactal feeding is common. So mothers, including other respondents, had different misunderstanding on the word immediate. According to them, it varies from some hours up to 2 to 3 days. And during that time, mothers would introduce like water, giving water to their infant. And the reason for delay of initiating breastfeeding was they were waiting for the milk to come down, or to wait until the infant learns how to suckle. So to avoid starving of the child, the water was given, and sometimes the water was sweetened by some sugar and salt to give the strength to the child. So when the child cries, was the first sign of thirst or hunger. As this was revealed by one mother from Mara region. So another finding was perception about exclusive breastfeeding, and this came in terms of quantity, quality of breast milk, and poor maternal diet. So the respondents, including mothers, perceived that the breast milk insufficient to nourish child. So according to them, heavy milk was thought to be more nutritious and satisfying for the infant, as he or she did not cry immediately after being breastfed. And light milk was termed as watery, and it was not good for the child growth and indicated not enough or too light to make the child grow. So women, another factor which contributed to to seeing that the women don't have enough milk was that they could squeeze their breast and find that there are no milk, but also they could touch the breasts and feel they are empty. So that one was also part of the findings. Maternal diet not enough and lack of appropriate food was also linked to insufficiency of breast milk. Mothers reported to not have enough meals, like some would have a single meal per day and have that hard kind of food. To them, the liquid kind of food would help them stimulate their breasts and breast milk. Early introduction of food as early as 3 to 4 months was commonly reported, and women were expected to return back to work, to farming activity or small economical activity, and this would affect exclusive breastfeeding and use of lactation or monorea method. So these are the quotes, one from a traditional birth attendant. She talked about the heavy milk and how it contributes to the growth of the child. And the second one, a mother explaining about how they get poor feeding or not appropriate feeding. So another finding is on the barriers to use of lactation or monorea method and postpartum family planning use. So mothers are reported to wait for their menses to return so that they start using family planning. If you look at the journal article, you find among the 24 mothers, it's only 4 who were under use of modern family planning method. So majority could give a reason that they are waiting to see their menses. Also, had a link between breastfeeding and birth spacing, yet LAM use was very low. So they knew that through breastfeeding, they are protected from getting pregnant. And that one is mothers up to, you saw, we interviewed the mothers up to their infant is 1 year. So they were also thinking that they are protected by breastfeeding. To that, we saw that they lack understanding around return to fertility. Postpartum return to sexual activity and fear of infidelity. Mothers resume to have sex within 3 weeks up to 1 month. And to them, it was their husbands were not patient to wait anymore. But also, they had fear of losing their loved ones to other women. They also had concerns regarding side effects of family planning, like it brings cancer, excessive breedings, and other more. So these are the quotes from one from a mother. She showed that she wanted to use family planning, but it was not possible because men were the ones to decide either to use or not. And the second one from the CHW in Kagera. So looking at all the challenges, we had to look to employ the cycle of care model, which shows entry points for facilitating social and behavior change. So before, we saw that there's a need for social and behavior change to motivate clients to access services. And this can be done by creating awareness at the community level and create a community dialogue which can address challenges and issues on gender norms. Also to engage community like influential people to start addressing the misconceptions surrounding family planning, but exclusive breastfeeding also. During services, we see there are gaps. These are the women who deliver from health facilities, but they delay even initiating of breast milk. So we see there's a need to improve the client-provider interaction by empower the clients to demand for these services when they go to the facility. But also the service providers have gap in providing and counseling for nutrition and also family planning. So there's a need to strengthen their knowledge and skills. Back to the facility, we see there's a need to follow up on the mothers. They need support. They need to be told about the challenges they face, especially in exclusive breastfeeding, use of LAM, lactational monolayer method, because you have to transit to another modern contraceptive method timely. So all these, we need community facility linkages so that they can communicate and refer some mothers to the facility timely. So reflections on sustainable approach for integration of nutrition in health programming. We see that we have to promote community and family support for exclusive breastfeeding alongside LAM and maternal nutrition during lactation. Here we saw that community and family support is vital to make these mothers exclusive breastfeed. Second is to increase understanding among mothers and fathers about links between MySen and PPFP and return to fecundity. We saw they lack the knowledge, so there's a need for the families to understand that the woman can become fertile even though she's breastfeeding. Engage facility and community providers to monitor LAM and facilitate timely transition to another contraceptive method and introduction and complementary foods. Lastly is to improve integration of nutrition and postpartum family planning services delivery. Thank you.
Thank you, Lemmy, for highlighting to us another contact point in health services that really we can make strides in nutrition, but maybe is less often emphasized in nutrition programming. We're about to get to our Q&A session, so think of your questions. Right now we're going to ask a few pointed questions to the panel, and then we'll open it up to the floor. So, Melanie, you mentioned ways in which micronutrient deficiencies are being addressed through various interventions. And you mentioned that other interventions are often are sometimes carried out by other ministries, like with food fortification. So can you tell us more about the role of engagement with other sectors, inside and outside of health, in Mozambique to advance nutrition?
Thank you, Janice. Actually, a very good and timely question for Mozambique, as I think the government recognizes, the government and donors, partners are more and more recognizing the need to strengthen that coordination. At the moment, let's look first at the health sector. There is, in the endorsement letter of the Nutrition Department of Health, there is an action point there of strengthening the coordination between the nutrition, immunization, and child health programs within the Ministry of Health, because they recognize that it's not possible to implement cohesive approaches if the communication between those departments are not improving. And from MCSP's experience, we see that there's nothing more difficult to handle than the confusion of frontline workers of not knowing which guidance to follow. Say, for instance, with the child health, the new registers, so there are nutrition indicators integrated there. But if the vitamin A supplementation indicator, which really just covers one dose supplementation of vitamin A, does not meet the requirements of the nutrition department, it's very likely that the nutrition department will request that they go back to parallel reporting. So if that's not tightened, it really does make things difficult at the field level. There's also an action plan that resulted from the integrating nutrition into the care of the ill and vulnerable newborn, that also recognizes the need to strengthen that coordination within the Ministry of Health. Now, for multisectoral collaboration, there has just been a midterm review of the Multisectoral Action Plan for the reduction of chronic malnutrition. And this coordination between sectors is a big gap that is identified, and there is a big need to coordinate. The only way to really implement cost-effective efforts is if these different sectors are communicating with each other. So there's also other donors. For instance, the FID is going to implement integrated nutrition and wash program, and they are currently conducting a scoping study to see what's not working in terms of coordination of those sectors, and how we can improve upon that, and governance and financing, and how to strengthen systems. So I think there is a general recognition that that needs to be strengthened, and it's a timely moment to support that.
Great, thanks, Melanie. And Lemmy and Florence, you both discussed monitoring of programs at the community and facility level as being key to sustaining the progress that the program saw. In your opinion, what are a few concrete ways that data quality and availability can be addressed and prioritized in your countries?
Thank you, Janice. To start with, I think the data quality of data problems in Malawi, we see them originating from various levels or perspectives. So it starts with, at the national level, not many indicators, or we haven't actually included BFHI indicators at the national level in HMIS or DHMIS2. So the starting point is actually to make sure that we have these indicators included in the national DHIS or HMIS. Secondly, when we look at why the problem of data is actually coming in Malawi, the main problem is to do with the people that are actually registering the information after a delivery has actually taken place. We are saying the maternity wards in Malawi are so much overburdened, are overloaded with workload, and then the health worker is overburdened, so much so that at the end of the day, they are taking the information to be entered in the register. They are giving it to somebody who is a lay person and has no clue whatsoever about the importance of this information that we are requesting them to enter in the register. So at that facility level, the main thing that we need to do is orient the person that we are requesting to enter data in the register. Afterwards, can we do repeated reviews? Let's say on monthly basis, we review whatever data has been entered together with these people. And then we keep on mentoring, we keep on coaching and supervising. That way, I think we could forge ahead with making data so much of quality. When we come to community level, because all those levels have got issues, we look at our community volunteer, like the one that we have used at the immunization program, when they are doing their immunizations and they are doing their growth monitoring visits. They are asking the community volunteer to track down the status of immunization for this particular child that has come. Therefore, BFHI is also requesting to do the same. Can this volunteer also track the status of exclusive breastfeeding depending on the age of the child? Thank you.
Thank you.
Hello, thank you for the question, and I'm going to respond as following. In Tanzania, information on counseling and initiation of exclusive breastfeeding is documented in the HMIS tools and in the postnatal register. And this will be followed up to when the child is 42 weeks. So we don't have the tools to track woman who is breastfeeding for the 6 months. So the recommendation for this, we thought that women still come back to the facility to bring their children for immunization services and growth monitoring services. So it's good to shift this information or to add the component on HMIS2 on RCH department and RCH card, which baby is followed on up to 1 year or up to, most of the women stop to bring their child when they have finished the immunization or vaccination services. So it's better to include that service in that another level of RCH because we are sure the women are going to come back. And we saw there are challenges on exclusive breastfeeding during the presentation. So there's a need to have community component, a strong community component, which links to the facility that, of course, in Tanzania we have CHW, community health workers, but they don't have any tools like to track women who are exclusive breastfeeding. But also they need to reinforce more information. I think we need to orient them deeply on how to support the women at the facility, at the community, and how to transition the women, especially who are using lactation or monorea method, because it's a short-term method, to timely transition to another modern contraceptive method, and to timely introduce complementary feeding to the child. So yeah, these are the two. The first one, to make sure the RCH follow up, they register the cards, include information on mothers' breastfeeding, but also to have to strengthen the community health facility linkages to follow the mothers and make sure they are supported throughout the continuum of care.
Thank you, Lemi. So now we can open questions to the floor. I think we have a couple people with microphones on the side and in the back, so just raise your hand. Looks like we have one right there.
Hi, Amy Kay, USAID Middle East Bureau. I have a quick question regarding your first question around multi-sector engagement. And I just wanted to know if any of you have any experience in terms of school feeding programs. I know we're getting into an older group of kids, but I just wanted to know in terms of, in particular, deteriorating health systems, if there has been any leveraging of that, and if you know of any models or success stories or lessons learned. Thanks.
So maybe we'll take a few questions and then we'll have the panel answer them.
Hi, thank you so much. That was so fascinating. I'm with Bread for the World Institute, and similar to the last question on the multi-sector approaches being used, have you looked into national social protection programs, safety net programs, like conditional cash transfers, particularly in the use of micronutrient powders? Is that, at what stage of opportunity would that be in your context?
Okay, let's take one more and then we can take another round as well.
Hi, Lara Ho from International Rescue Committee. Thanks so much for the great presentations. I had a question about the presentation on family planning and nutrition integration, and there seemed to be a lot of focus on LAM, and I was curious whether IUDs were presented to women and discussed as an option, since they're a lot more effective and they reduce some of those issues of gaps between LAM and transitioning to another method. Thanks.
All right. Does anyone want to speak to the question of school feeding experiences or the national safety net programs?
Thank you very much, Janice. And the question as it regards. In Malawi, we have school feeding programs, but I haven't actually had the detailed experience or any experience as regards to how it is implemented or what they are achieving, what their problems are and the successes are. I'm just aware that we do have school feeding programs and they are scattered all over the country. At our technical working groups, I think we haven't had even somebody from Ministry of Education, so that is a fruitful thought. Thank you.
Perhaps I can just add that FAO in specific provinces of Mozambique has been working with not necessarily school feeding programs, but maybe education, nutrition education programs within schools. And they have had some quite good success in improving behaviors and having children themselves develop, drama pieces on nutrition that are quite effective with this older age group at changing nutrition behaviors. I don't have a lot of experience with school feeding programs to comment a lot more to that question, but would be happy to learn more about your experience and discuss.
Okay, I'm going to respond on the why LAM, why not other family planning methods during my presentation. We thought that LAM is one of the family planning methods, but was not coming up in our country, that it's under the table. So this study looked at how we can bring it up again. That's why I talk about LAM all the time. And yeah, during the, we were looking for information about all the postpartum family planning methods. And even during my presentation, you saw that mothers were breastfeeding and think that breastfeeding prevents them from getting pregnant. But no one mentioned that I'm using LAM. So you see how this method was under the table. And you saw people in Tanzania, they still have much misconception surrounding modern contraceptives use. So we thought by keeping it up, it will protect women for the first 6 months, and then think of how to reinforce more information on family planning, modern family planning, for them to transition to other family planning method, than leaving the mothers from the beginning to the end without any family planning method. So the answer is, yeah, we are looking to hear about all the family planning method, but we really had to focus on LAM use because we are planning to go further and implement another intervention level to bring it up.
Thanks, Lamine. Before we get to more questions on the floor, we did get one from online addressed to you, Lemmy. Regarding the indicators that you showed on the first slide, there were some slight declines or some stagnation with the unmet need and the modern contraceptive prevalence rate. So the question is, what happened in 2010 that stalled progress over the next 5 years? Do you have any insights to that?
Okay. Yeah, the graphs, as I presented, like unmet need, it was stagnant throughout. And modern contraceptive use is still low. And this is among the currently married women. And yeah, the country is working hard to bring up the family planning. We have so many going on at the country level. The ministry is up, Minister of Health is up front, making sure that women join contraceptives, immediate postpartum contraceptive use. But still, I think we have to work hard. Still, as I told you, among the 24 women we interviewed, only 4 were in family planning. We see the obstacles from partners. Not that men are not allowing their women to go for family planning, but they don't have knowledge on how family planning are doing, like they are not harming their wives and what. But if they get that knowledge, men will be so supportive on that. And this is one of the findings from our formative assessment. Also, the services are there and free. No one is supposed to pay even a single cent for family planning methods in all the facility from lower levels. So it's a matter of behavior change and misconceptions surrounding the family planning, but with social and behavior change approaches and community engagement, we know at the community level, like in the remote, influential people can make a change. So we should try to look on different points where we can reach the community, but also health facilities. The providers should be ready to provide these services. They should be ready to counsel women. They are overwhelmed. They don't have enough time to sit with women and talk to them in detail about family planning. In Tanzania, we have that first visit where couples go to the facility if a woman is pregnant because they have to test for HIV. So that's another opportunity where male and female or a couple can be reinforced on key issues like these: family planning, support to the lactational mothers, and other information, which are missed opportunity in most of the facilities in Tanzania.
Thank you, Lemi.
Yeah.
And just to go back also, Melanie mentioned she had a comment about the social safety net programs in Mozambique.
Thank you for the question. I think the links between nutrition and social protection, as far as my knowledge goes as well, is very much related to nutrition care for orphan and vulnerable children, as well as the use or the provision of breast milk substitutes for children who for some reason cannot access breast milk, and sometimes the criteria are not necessarily followed as they should. But I think there is a huge opportunity with, as you said, conditional and unconditional cash transfers, as the recent evidence has been showing that cash transfers can in themselves improve nutrition. And I think there is a lot of interest in the country about the effect that cash transfers can have in really improving nutrition practices. I know that UNICEF is going to implement a pilot and be testing that out in Nampula and perhaps other provinces as well. So I think there's a very good opportunity there to study the links, and the Ministry of Health, and for the Ministry of Health to really consider improving the dialogue with the Ministry of Gender, Child and Social Protection.
Thanks. So we have a few more questions and we'll take a few more.
Hi, this is Kate Litvin with USAID Advancing Nutrition. I just had a question in regards to Dr. Buda's presentation when he mentioned, that we need to integrate nutrition into the governance, information system, and financing building blocks. But in these 3-country contexts, we've seen key challenges around overburdened health facilities, lack of domestic resources, and weak information systems. So thinking back to Dr. Buda's point, do any of you have examples of how you work to strengthen governance or information systems or financing within your programs? Thanks.
Thanks. We'll take a couple more.
Hello, I'm Altrina Mukuria from Advancing Nutrition, and thank you so much for that enlightening presentation and showing us not just the successes, but the challenges that you have encountered in trying to integrate nutrition into other services. I think we can move the field so much further when we learn some of those challenges and not just focus on successes. Dr. Buta also mentioned that by integrating nutrition into other services, we don't take away from those services. But in your presentations, you weren't able to show how it enhances the nutrition services and nutrition outcomes. So maybe also piggybacking on the previous question, that what are some of the health system strengthening aspects that may be able to help to strengthen or improve effectiveness of the nutrition outcomes? Do you think may be lacking or need to be addressed?
Thank you very much for the presentations, and congratulations to you all for the journal supplement. It's really nice to have all of this documented in such a rigorous way. I'm Tina Loren, and I'm also from the USAID Advancing Nutrition Project. I just have a question when you think about the successes that you've had, the way that you've been able to make progress, and thinking about sustainability after MCSP ends. I think it was Ms. Florence, you mentioned incentives, incentivizing the BFHI hospitals, the ones that were certified. So if you could talk about, in your context, what kind of incentives have you seen that have worked and worked towards sustainability? Thank you.
All right, and I think we'll take one last one, and then they'll definitely be up here afterwards for any further questions.
Good morning, and thank you for your beautiful presentations. I'm Ochi Ibe with MCSP. I have two questions. One is addressed to the speaker from Malawi. You had talked about the phased approach of BFHI, and one of the things you talked about was increasing linkages to the community. And I thought that BFHI has a community BFHI component or program, and I'm wondering to what extent that was rolled out in Malawi. And then the second question points to something that Justin had highlighted, which is the scaling up nutrition. I know your supplement focuses on integration into the health system, but I just wanted to know, across the 3 countries, how is the multisectoral nutrition strategy under the scaling up nutrition being implemented, and some of these interventions that you have highlighted being integrated into that multisectoral strategy. Thank you.
We have quite a number of questions here. Florence, we had a few that were directed towards you. Would you like to answer those first?
Thank you so much, Justine. Indeed, I talked about as one way of sustaining BFHI in Malawi is to incentivize. And basically, the sort of incentives that are looking at, or Malawi at the moment is already doing, is to, when a hospital has become finally baby friendly, can we gather at that particular hospital and provide the hospital with a recognition, yeah? This recognition, basically, all you are doing is getting a shield and getting a certificate to be presented to that particular facility. But you don't do it just with that staff only for that particular facility. You are having to make it more big by bringing in the Minister of Health to actually present, and the members of staff, they feel very, very proud. They dance. It's like an open day, actually. So the other hospitals that have not made it, they also get invited, and they get inspired by whatever is happening at that particular moment, and they feel, our friends have done it, why can't we? That's the one that at the moment we are doing in Malawi, and I feel it is actually working. As regards to linkages at community level, with MCSP, I talked about we oriented 1,400 community volunteers with the intention of having at community level, can the community volunteer keep it tracking each baby that is born in their particular community with at what stage or what's happening as regards to exclusive breastfeeding. So the community volunteers have been informed that the best to do is for every baby below the age of 6 months, they have to be given nothing else but the mother's breast milk. So most of the community volunteers involved the chiefs, and the chiefs are the custodian of culture in Malawi. Once the chief feels this particular mother is not doing according to the guidelines and according to what I want my people in my village to do, they are taken to task. So that is as how much as we have done, or we have gone with BFHI at community level. At the moment, I'm still continuing that particular work, but with a different project. We have also done similar.
this time around, I'm sure we have oriented more than, because what we have done is each district that we have reached, we are linking up with the community care groups. And the community care group, the way it is actually established is you have lead people or lead persons or cluster leaders who take care of other promoters that are about 10 or so, and they spread in their different villages, and the message is the same. Can they track down the practices as regards to every mother with a child before the age of 6 months? What is it that they are feeding them? Thank you.
Thank you, Florence. And just being cognizant of time, Melanie, maybe you could give us an example, if any, on ways that the program was working to improve governance, financing, or information systems in terms of the health system and nutrition.
So governance per se may have not been the focus of the program, but more on helping adequate planning of nutrition, health services, and integration. So we would support at the various levels, central, provincial, district levels, on the development of annual socioeconomic plans for health, which includes all these different programs: nutrition, maternal, child health, immunizations, etc. So we would be helping them to understand what the problems are, ensure that the priorities are reflected in the plan, as they do need to prioritize. The resources are scarce, and to budget that out. But to address the problems with financing, etc., it relies a lot on collecting the data and using that for advocacy and informing resource allocation and government priorities, which I think is something that needs to be strengthened in the future as well. I don't think we're doing enough of that in the country. As for health information systems, finally, that was a key piece of what we did, from developing health information tools, like the child health tools, which we really did support the Ministry of Health in developing and piloting and rolling out, as well as ensuring that many of these tools and indicators are integrated in the HMIS platform, and supporting the collection, the reporting, the analysis, and the use of data for decision making at the different levels, particularly at the health facility and community facility and district levels. So that's what we can contribute.
Great. Thanks. And maybe we can finish with you in the question about how integration doesn't necessarily take away from services, but how can we ensure that it's also enhancing the outcomes for nutrition? So in your experience in Tanzania, how can you see this formative research helping advance the nutrition outcomes as part of the postpartum family planning programming?
Okay, thank you. During the formative assessment, we saw that the opportunities, because mothers goes to the facilities in a different time point. So if we reinforce the existing system, the providers at health facilities, make sure that they have all the information, they can provide these services in an integrated manner. Very simple, no additional resources. It's just a behavior change. Because they have the mothers, they have the infants, they provide the same services. And to them, I think integrating these services will make for them the work more easier, because at the same time they are counseling a mother on exclusive breastfeeding, they can integrate use of lactational amenorrhea method, which is family planning method. So using the same time point, provide the integrated services, and yeah, I think everything is okay, and that's possible. It can be done. We just need to strengthen their capacity, provide knowledge to them, make sure they are motivated to work, creating good environment for their work, like the facilities should look good to make them happy also, waking up, going to the work. So that way I think the integration will be done with no additional costs, using the same existing health systems.
Thank you, Lemmy. Thank you to all. Maybe a round of applause again just for our presenters today. And now I'd like to invite Dr. Chesa Letter. She's the Senior Nutrition Researcher at RTI International and also a visiting research professor at the University of Maryland School of Public Health, to wrap up and make sense of all these interesting conversations.
Thank you, Janice. I'd like to thank USAID and the MCSP program for the opportunity to give some summary comments, and I should say the challenge of doing so, and really to congratulate the MCSP program and today's speakers for the really enormous amount of work that has been done, and the really careful documentation. I think one of the questions really pointed out to that. I think too often we lose the richness of what we're doing in the field. It's a great white paper. It exists maybe on some website somewhere, but if you want to really search for it, it sometimes just doesn't turn up. And just going through a supplement like has been gone through really provides a level of rigor and accessibility that we can all use as we move forward in research and programs to really strengthen maternal and child nutrition. I think it's also important to note that today's speakers have really shown all the work that they've done, but been very honest in their constructive criticisms about what the challenges remain. So it's not just a feel-good story, but it's really helping us to think and ask some hard questions about maybe why aren't some things working, and maybe how should we change what we're doing to have more success. And I think lastly, really, that the importance in thinking or recognizing USAID for supporting this really and critically important work. So globally, we know a lot about what it takes to improve child nutrition, and we really know mostly from those interventions through the health sector. I think the Lancet series, publications from Zufi Bhutta and his colleagues have really shown us kind of the what to do. But clearly what's come up during this set of presentations is, we lack how to do it, who the mother and father trust most to give the messages, and where and when it's best to give specific messages. I mean, how do we sequence our social behavioral change communication, discussion around family planning methods, et cetera, to really use the different opportunities for synergy to reinforce these messages. And the set of presentations today, from Tanzania, Malawi, and Mozambique, start to give us this kind of information, how we can improve the delivery of specific nutrition services, and really importantly, how we integrate these into different health actions for multiple impact. Oh my gosh, 2 minutes. Well, I better really speed things up. So I think just what Dr. Bhutta asked about, I think importantly that what we're doing, we may not have a lot of evidence or the extent of evidence of its impact. We know that it's not detracting from the core function of those specific activities. And I think, so that really speaks to the opportunity cost of what we're doing. And I think just to take this a step further, the opportunity cost of the different nutrition interventions and if we're getting the right balance right. I think this leads really well into the first presentation on the micronutrients and the really well-articulated concern, is there really vitamin A deficiency? The last data from 2002, the last DHS shows that 80% of kids between 18 and 23 months of age are getting a vitamin A-rich food. The acceptance of the sweet potato. It really asks, I think begs the question, do we need to be doing this, and that we need more data to be driving these decisions. Unfortunately, as I learned, trying to get more light on this, the question in DHS about night blindness during pregnancy was dropped after round 5. So again, that could have been a really good way to maybe get some information about vitamin A deficiency, because there's a link between night blindness during pregnancy, something that tells us and about what may be going on with children. I think we need to ask ourselves not only what's working well, but what maybe we don't need to be doing that anymore, especially if we're doing NMPs and other interventions. The BFHI, very critical, and so much success. But again, are we using also the BFHI to really emphasize, are we using opportunities to talk about breastfeeding to be talking about other important issues? Family planning, for example. I'm so happy to hear this presentation, because I think we haven't taken advantage of links to promote family planning. I mean, all the lists of things that a child will benefit from by delayed spacing of birth, the time of first birth. I got to wrap it up. Okay. I think one thing that wasn't mentioned that I think is critically important, if we can delay that first birth among an adolescent, she can continue her education in many cases, and we know that's an important risk factor. Low maternal education is a risk factor for poor nutritional statuses. So I think this family planning, we've got to bring it more to the forefront. And I think this supplement, this presentation, is a huge step in that direction. Because again, as we talk about WASH, as we talk about ag, we don't talk about family planning and the importance of that for young child nutrition. So I think that's just a huge step in the right direction. I think I share the concern that was raised in the questions about, are we transitioning at the right time from LAM to family planning? 6 months is probably too late if, between 4 and 5 months, exclusive breastfeeding has really dropped off. How, can we use that first prenatal visit, as you so rightly pointed out, to really start this conversation and bring men into the discussion? Because again, as the qualitative research showed, their views are just so important. And to wrap up, because I'm getting, I wouldn't say the evil eye, but I am definitely getting signals here. Let's just talk about data for a minute. Data-driven decisions, okay? And I think really asking some questions about, process indicators, outcome indicators, when is it best to do what, and the opportunity cost of collecting some data when maybe we should really be doing other things. And I think, again, this was brought up nicely. Do we use those visits to reinforce about exclusive breastfeeding, the messages about how to support women to exclusively breastfeed? Or do we try to get it, collect information about, are they exclusively breastfeeding? That's a tough indicator to get at, particularly if you're a community health worker and the health services are overburdened. So, really thinking hard about what data, for what purpose. What are we going to do differently if we get that number? And so, again, just really thinking about what that data is for, when we should collect it, and how we should collect it. And I think I'll close with those remarks, again, to congratulate the speakers, the Justine, and everyone who's made such huge contributions to this very successful supplement and project. Thanks.
Thank you, Chessa. Thanks, Chessa, for those really thought-provoking summary remarks. We're going to invite Dr. Jim Ricca, the Learning and Implementation Science Team Lead, to close this out. And while he's coming up here, we just want to remind everyone that the link to the journal will be on the MCSP event webpage later today. It is open access and online, and also the recording of today's event will be there as well. Thanks, Jim.
Okay, thanks, Janice. I won't keep you very long. I just wanted to say that we've heard some really thought-provoking review and 3 country experiences. I encourage you all to read either online or in your packets in hard copy, some of the other experiences that are reflected there. And then just in closing, I want to reflect on a couple of points. First, resilience of the health system of the population is impossible without taking account of nutrition. Infant and young child feeding, breastfeeding, micronutrient supplementation, and nutritional rehabilitation interventions are critical parts of the health system. But having a system orientation is obviously critical for being able to make sure that those things are delivered in an integrated way so that it's sustainable and will work in routine systems. So we've heard some really great things, some interesting country experiences, and I think with some of the warts as well, not everything worked, but obviously a lot of things did work quite well, and I think it's interesting to reflect on what worked and what didn't among the things that Lemmy, Florence, and Melanie told us about from the various country experiences. So I just think in summary that the nutrition community and some of these experiences have a lot to talk to us about the journey towards self-reliance, toward countries being able to better plan, implement, and finance their own programs, both in nutrition and health in general. These experiences were not just kind of small scale and not just kind of research, but really kind of thinking about how things work in routine practice at scale. So on behalf of my colleagues at MCSP, I wanted to sincerely thank all the ministries of health for helping us and for working with us together to give us the opportunity to help them on their journeys to self-reliance. I wanted to thank the Kaiser Family Foundation for this fantastic space that we're in. I wanted to thank the Journal of Maternal Child Nutrition for working with Justine and the rest of the MCSP nutrition team for putting together this timely supplement. Thank all the speakers as well. Thanks very much for all the reflections you've given us. Thanks to Janice and Barbara and others at USAID for the support they've given us for this launch event and for the nutrition supplement. And finally, I want to thank all of you for either braving the weather or the wilds of the internet and Twitterverse for those of you who joined us virtually to hear about these experiences. Thanks.